Endless History of Allergic Rhinitis. Presented by Dr. Jalal, Mohsin, Uddin, M.B.B.S, D.T.C.D, FCPS, Pulmonology. Introduction. Allergic rhino-conjunctivitis, sinusitis and asthma are common diseases and often coexist in an interdependent nature in the same patient. Rationality of this presentation. Upper and lower allergic respiratory diseases constitute an important global health problem, and a progressive increase in their frequency in the modern world has been seen in recent years. Recognition of their commonality as different manifestations of one disease entity will ultimately improve the diagnosis and management of patients with these common disorders. Why we should treat allergic rhinitis. Uncontrolled rhinitis may be associated with worsening of coexisting asthma, and effective treatment of allergic rhinitis usually improves the associated asthma. The key to managing both entities, therefore, is prevention and relief of chronic allergic inflammatory changes in both the upper and lower airways. A new term, allergic rhinobronchitis, has been proposed to describe this relationship. The pathophysiologic link between allergic rhinitis and sinusitis includes inflammation caused by nasal allergy leading to obstruction, fluid accumulation and bacterial infection. Persistent inflammatory changes cause mucosal damage and a chronic state resulting obstruction and infection. Acute disease may become chronic. Diagnosing and prophylactically treating nasal allergies may prevent recurrence and improve therapeutic responses in sinusitis. Global allergic treatment affects both the upper and the lower airways. The use of nasal corticosteroids in subjects with rhinitis and asthma reduces not only rhinitis symptoms but also asthma symptoms and decreases the non-specific bronchial airway reactivity to methacholine. Similarly, antihistamines improve the pulmonary function tests of these patients. There is a consistent observation in many patients that control of asthma remains difficult when their sinus disease is not treated. And appropriate treatment of their sinuses frequently results in improvement of their asthma. If you miss post-nasal drip, usually associated with chronic rhinitis and sinusitis, you may lose cause of chronic cough. Upper airway examination is mandatory for pulmonologist. Allergic ocular diseases are often associated with seasonal allergic rhinitis. Allergic conjunctivitis is part of the hay fever syndrome. Atopic subjects frequently present. Allergic rhino-conjunctivitis. Atopic keratoconjunctivitis. Vernal keratoconjunctivitis. Giant papillary conjunctivitis. Ocular contact allergy. Why we should know about allergic rhinitis. The WHO, World Health Organization, now classifies allergic disease as the fourth most important chronic disease in the world. Respiratory allergies have doubled in the space of 20 years, 1986 to 2006. Faced with this trend, prevention and treatment of the disease have become major public health issues. 1 in 4 people suffer from respiratory allergies. 500 million people in the world suffer from allergic rhinitis, of whom 15 to 20% have severe symptoms. How we can classify allergic rhinitis. A classification was developed by the area, Allergic rhinitis and its impact on asthma, in order to characterize rhinitis and its impact on the quality of life according to its duration, intermittent or persistent, and the severity of the symptoms. How we can classify allergic rhinitis. Continue. Intermittent rhinitis occurs less than 4 days per week and for less than 4 weeks per year. Moderate to severe rhinitis, incapacitating symptoms accompanied by discomfort during day-to-day work or school activities as well as disruption of sleep. Mild rhinitis, minimal symptoms having little impact on sleep and day-to-day life. Intermittent symptoms 4 days per week or 4 weeks. Persistent symptoms 4 days per week and 4 weeks. Mild. Normal sleep pattern. Normal social and leisure activities. Normal school or work activities, only slightly bothersome symptoms. Moderate, severe, disturbed sleep pattern. Disturbed social and leisure activities. Disturbed school or work activities. Bothersome symptoms. Management. The management of allergic rhinitis consists of 3 major categories of treatment. 1. Environmental control measures and allergen avoidance, 2. Pharmacological management, and 3. Immunotherapy. Algorithm for the treatment of allergic rhinitis. Allergic rhinitis. Allergen avoidance and patient education. Mild intermittent symptoms. Mild to moderate persistent symptoms. Severe persistent symptoms. Second generation oral or intranasal antihistamine, as needed. Intranasal corticosteroids alone as first-line treatment. Consider nasal irrigation or decongestants for nasal congestion. Consider ipratropium, Atrovent, or intranasal antihistamines for rhinorrhea. Consider oral or intranasal antihistamine for persistent nasal ocular symptoms. Intranasal corticosteroids plus oral or intranasal antihistamine, oral leukotriene receptor antagonist, or intranasal cromolyn, nasalprom. Symptoms persist. Consider immunotherapy referral or alternative treatments, for example, allergen avoidance, nasal irrigation, acupuncture, probiotics, herbal preparations. Use of nasal decongestants for longer than 3 days is cautioned because of risk of rebound congestion. Environmental control measures. Environmental control measures and allergen avoidance involve both the avoidance of known allergens and avoidance of non-specific core irritant triggers. However, global environmental control without identification of specific triggers is inappropriate. Pollen is shedding from flowers. Tips regarding environmental control. Reduction of outdoor exposure during the season in which a particular type of pollen is present can be somewhat helpful. Pollen counts tend to be higher on dry, sunny, windy days. Outdoor exposure can be limited during this time. Keeping the windows and doors of the house and car closed as much as possible during the pollen season can be helpful. Taking a shower after outdoor exposure can be helpful by removing pollen that is stuck to the hair and skin. For dust mites, covering the mattress and pillows with impermeable covers helps reduce exposure. Bed linens should be washed every 2 weeks in hot, at least 130 degrees Fahrenheit, water to kill any mites present. Thorough and efficient vacuum cleaning of carpets can help, but, ultimately, carpeting should be removed. Take control measures for mold allergy. Focus on reduction of excessive humidity and removal of standing water. For animal allergy, complete avoidance is the best option. Cockroach elimination may be helpful in cases of cockroach sensitivity. Groups of drug used in allergic rhinitis. Treatment type. Ocular symptoms. Nasopharyngeal itching. Sneezing. Rhinorrhea. Intranasal corticosteroid. BLAS. 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 Oral antihistamine. BLAS. 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 Intranasal antihistamine. BLAS. 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 Decongestant. BLAS. BLAS. Intranasal cromolyn. BLAS. 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 Intranasal anticholinergic. BLAS. Leukotriene receptor antagonist. BLAS. BLAS. Treatment type. Ocular symptoms. Nasopharyngeal itching. Sneezing. Rhinorrhea. Nasal saline irrigation. BLAS. Immunotherapy. Plus. 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 Clinical recommendation. Clinical recommendation. Evidence rating. The initial treatment of mild to moderate allergic rhinitis should be an intranasal corticosteroid alone. A. The adverse effects and higher cost of intranasal antihistamines, as well as their decreased effectiveness compared with intranasal corticosteroids, limit their use as first or second-line therapy for allergic rhinitis. A equals consistent, good quality patient-oriented evidence. B equals inconsistent or limited quality patient-oriented evidence. C equals consensus, disease-oriented evidence, usual practice, expert opinion, or case series. Clinical recommendation. Clinical recommendation. Evidence rating. Although safe for general use, intranasal cromolyn, nasalcrom, is not considered first-line therapy for allergic rhinitis because of its decreased effectiveness at relieving the symptoms of allergic rhinitis and its inconvenient dosing schedule. C. Nasal saline irrigation is beneficial in treating the symptoms of chronic rhinorrhea and may be used alone or as adjuvant therapy. B. Important features of drugs of allergic rhinitis. Treatment. Pregnancy category. Minimum age. Mechanism and onset of action. Adverse effects. Intranasal corticosteroids. Piclomethazine. C. 6 years. Inhibits the influx of inflammatory cells. Onset of action is less than 30 minutes. Bitter aftertaste, burning, epistaxis, headache, nasal dryness, potential risk of systemic absorption, rhinitis medicamentosa, stinging, throat irritation. D.T.C.D. B. 6 years. Sickle snide. C. 6 years. Mometazine. C. 2 years. Fluticasone furoate. C. 2 years. Fluticasone propionate. C. 12 years. Triamcinolone. C. 12 years. Important features of drugs of allergic rhinitis. Treatment. Pregnancy category. Minimum age. Mechanism and onset of action. Adverse effects. Oral antihistamine. Blocks H1 receptors, onset of action is 15 to 30 minutes. Dry mouth, sedation at higher than recommended doses. Cetirizine. B. 6 months. Disloratadine. C. 6 months. Fexofenadine. C. 6 months. Levocetirizine. B. 12 years. Loratadine. B. 2 years. Important features of drugs of allergic rhinitis. Treatment. Pregnancy category. Minimum age. Mechanism and onset of action. Adverse effects. Intranasal antihistamine. Blocks H1 receptors, onset of action is 15 minutes. Bitter aftertaste, epistaxis, headache, nasal irritation, sedation. Azilastine. C. 5 years. Olopatadine. C. 6 years. Important features of drugs of allergic rhinitis. Treatment. Pregnancy category. Minimum age. Mechanism and onset of action. Adverse effects. Oral decongestants. Vasoconstriction, onset of action is 15 to 30 minutes. Arrhythmias, dizziness, headache, hypertension, insomnia, nervousness, tremor, urinary retention. Pseudoephedrine. C. 12 years. Intranasal anticholinergics. Blocks acetylcholine receptors, onset of action is 15 minutes. Epistaxis, headache, nasal dryness. Ipratropium. B. 6 years. Treatment. Pregnancy category. Minimum age. Mechanism and onset of action. Adverse effects. Leukotriene receptor antagonists. Blocks leukotriene receptors, onset of action is 2 hours. Elevated levels of alanine transaminase, aspartate transaminase, and bilirubin. Montelukast. B. 6 months. Intranasal cromolyn. Inhibits histamine release. Results typically noted in 1 week, but may take 2 to 4 weeks for full effect. Epistaxis, nasal irritation, sneezing. Cromolyn. B. 2 years. Immunotherapy. Immunotherapy should be considered for patients with moderate or severe persistent allergic rhinitis that is not responsive to usual treatments. Targeted immunotherapy is the only treatment that changes the natural course of allergic rhinitis, preventing exacerbation. Immunotherapy. It consists of a small amount of allergen extract given sublingually or subcutaneously over the course of a few years, with maintenance periods typically lasting between 3 to 5 years. The greatest risk associated with immunotherapy is anaphylaxis. Although the usefulness of sublingual immunotherapy in adults with allergic rhinitis has been supported by several large trials, studies in children have met with mixed results, and the FDA has yet to approve a commercial product for sublingual use. Omalizumab, Xolair, an anti-immunoglobulin E antibody, has been shown to be effective in reducing nasal symptoms and improving quality of life scores in patients with allergic rhinitis. The main limitations of its current use are its high cost. Average wholesale price is $679 to $3,395 per month, and lack of FDA approval for home use. How to use a nasal spray. Shake the bottle. Blow your nose so that your nostrils are clear. Wash your hands. Take the lid off the bottle. Tilt your head slightly forward. Close one nostril by gently pressing against the side of your nose with your finger. How to use a nasal spray. Insert the tip of the nasal spray into the other nostril and start to breathe slowly through your nose. While you are still breathing, give one spray into the nostril, keeping the bottle upright and slight laterally. Remove the spray from the nostril and breathe out through your mouth. Tilt your head backwards to allow the spray to drain into the back of the nose. Nasal irrigation and saline sprays. Cleaning the nose with a salt water, saline, solution is called nasal irrigation or nasal lavage. Saline is also available in a standard nasal spray, although this is not as effective as using larger amounts of water in an irrigation. Nasal irrigation is particularly useful for treating drainage down the back of the throat, sneezing, nasal dryness, and congestion. Nasal irrigation and saline sprays. The treatment helps by washing out allergens and irritants from the nose. Saline wash also clean the nasal lining. Can be used before applying sprays containing medications to get a better effect from the medication. Take-home messages. Allergic rhinitis, sinusitis and asthma are the diseases of the same airway. Asthma will not be controlled if allergic rhinitis and sinusitis are not combinedly treated. Every pulmonologist should examine the upper airway in his/her chamber. Intranasal corticosteroid is the main drug in the management of allergic rhinitis. Thank you all. Endless history of allergic rhinitis. Learning pulmonology.